good afternoon, everybody. I'm Marc Ferrini from Lyon, and I'm a general cardiologist, and I work in office and in hospital in St. Joseph Hospital. I'm going to talk to you about frailty in elderly, especially in TAVI. I focus my speech on TAVI. I have no disclosures. I think you hear me well. It's okay. Everything is okay. Do you hear me? Yes.
Yes, we can.
So, when you propose a patient for TAVI, you have, of course, to look at the balance between benefits and risk. And of course, you expect some benefits. Immediate benefits are to, first of all, you have your patient must survive, of course. You must avoid acute complication, and you must allow him to go home safe. And the first target is to relieve aortic stenosis burden, improve dyspnea, improve left ventricular function. But other objectives are expected in medium or long term. You have to improve physical function of the patient, maintain cognitive function, let him stay home safe for long term. You have to improve his quality of life and allow him to live longer. And facing to these benefits, you have some obstacles to these benefits that are poor mobility, weakness, fatigue that may alter physical function, incomes of stroke, of progressive dementia that will alter cognitive function, repeated procedures and hospital readmissions that will prevent him to stay home safe, disability, depression, social isolation that will alter his quality of life, and of course short-term death that may occur. And what is important for my speech is that frailty intervenes here because frailty has a negative impact on each of these benefits expected. So that's why we have to try to detect and to quantify frailty in these patients, in older patients that are going to benefit from TAVI. So let's go back to this balance between benefits and risks. You know that it's up to the multidisciplinary heart valve team to define which patient are to go to surgery or TAVI. But what is interesting for me is this little part of population in which TAVI may be futile because too risky. So are there some patients in which frailty make TAVI futile and for which we must refuse to do TAVI and orient them for another kind of care? Not the question. So let's begin with the definition of frailty, and that's the first $1 million question. From the beginning of this century, frailty has been defined as a multidimensional geriatric syndrome characterized by an age-related state of decreased physiological reserves with increased vulnerability and loss of adaptability to stress. And this was leading to adverse outcomes. That means falls, delirium, disability, hospitalization, and mortality. But next to this definition, it's important to see that from the beginning, pre-frailty has been defined as a clinically silent and reversible stage preceding frailty, in which physiological reserves are sufficient to respond adequately to stressors. That means that the concept was that maybe there is a state preceding frailty, and if we can detect this state, we can treat him and prevent or delay the income of the real frailty. The problem is that there is a very important lack of consensus on the definition of frailty and on the different measures that has been used for its screening. And that there is too an absolutely not clear consensus about the pathophysiological mechanism of frailty. And we could say that, yes, I cannot define frailty but I know I can't recognize it when I see it. This last year, some basic points can be pointed out anywhere. First, frailty is multidimensional with physical and psychosocial factors that play a large part in its development. Frailty is an extreme consequence of the normal aging process. And some people have defined it as an energy dysregulation. Frailty is dynamic. That means that an individual can fluctuate between different states and between different severity stage of frailty. And at last, frailty is potentially preventable up to a probable point of no return. And at this point, it becomes a pre-death phase. But the problem is how to determine that the patient is at this point of no return. Risk markers for frailty are known and are very numerous. They are demographic, social, like age, female sex, low education, and so on. Clinical, like multimorbidity, obesity, malnutrition. About lifestyle, physical inactivity, low protein intake, smoking, alcohol, and some biological features. All these features may lead to onset or progression of frailty. So, how to define this frailty? At the beginning, two conceptions have been pointed out. First, frailty, there is a phenotype of frailty defined by the presence of the absence of some features. So this score was based on 5 features: unintentional weight loss, self-reported exhaustion, low energy expenditure, slow gait speed, and weak grip strength. In fact, these features are quite easy to determine in clinical cases. So you have 5 features. Each feature is 1 point. If you have 3 or more than 3 points, you're frail. You have no point, 0 point, you're not frail, and 1 or 2 points, you are pre-frail. That's the first concept. The second concept is that frailty is made of an accumulation of deficit. So we have to count all numerous health deficits, at least 30 deficits, such as signs, symptoms, diseases, disabilities, abnormal tests. And you can build a frailty score that is the sum of health deficits present divided by the total number of deficit measured. That means, for instance, if a patient has 10 of the 30 diseases, well, the score will be 10 over 30. That means 0.33. So the higher the score is, the higher is the degree of frailty, the score going from 0 to 1. The problem is the cutoff. That is very controversial, but most of the time it has been defined that a score higher than 0.25 is the definition of frailty. More recently, some electronic scores have been pointed out, like the electronic frailty index or the hospital frailty risk score. This score measures the number of multimorbid conditions, but the originality is that they are generated from electronic health record data. That means that this data is directly extracted by the files of the hospital, of institutions, and they are treated by algorithms. And the score prognostic value of this score may be automatically incremented using the big data. The big data works. The major advantage for clinicians of this electronic score is that they are not obliged to extract the data from each file. It is done automatically by the electronic work. So, other problem. How to assess frailty? And we see that the first problem is the very numerous, the large number of scores that have been used to define frailty. Let's see in this table the result of about 10 works that have been published about frailty and TAVI. As you can see, the criteria of frailty are absolutely different from in each of these publications. And you can count more than 20 different measures that have been used for screening frailty. And the problem is that we don't know what which one fit better concerning the prediction of mortality and the potential response to intervention. And we don't know the sensitivity, specificity in identifying the older adults at risk of each of this scores. And the problem is that the use type of these scales matters, because look at this publication on about 1,000 people going to TAVI or aortic surgery. Depending on the scale that you use to define frailty, you can have a prevalence of frailty that goes from 35 to more than 70% patient. And that matters because not only the prevalence, but the prognosis, of course, is absolutely different. So let's go on, because I would just let you see two more recent works that are interesting. The first one is a Medicare publication, Medicare patient older than 65, and it's the analysis of almost 30,000 patients treated by TAVI during the year 27, excuse me, 26th in the US. These patients have been tested with the hospital frailty risk score that allows to determine a low risk or low frailty risk in the green line, and the high frailty risk. And of course, you see that at 1 year, the mortality is extremely different in the low risk, less than 10%, than in the high risk, where mortality is more than 30%. And this is the case not only for mortality, but for hospitalization, for the income of acute myocardial infarction or stroke. And the absolute risk of these complications is 3 to 4-fold higher when a patient is in the high frailty risk. So yes, we can stratify the risk of this patient using this score. That's the first point. The other publication is a prospective multicenter cohort of about 1,000 adults of 80 years old with symptomatic aortic valvular stenosis undergoing TAVI or surgery. And the aims of the publication was to compare the incremental predictive value of different frailty scales, and between the scales, the essential frailty tool set. That is quite simple tool. You have to determine the power of the possibility for the patient to rise from his chair, the existence or eventual existence of an impairment of a cognitive impairment, the low hemoglobin or low serum albumin, and that allows you to give a score from 0 to 5. And look at this table. If you have a patient who has a score of 5, well, this patient will present a 65% mortality at 1 year. And if you look at the sum of death and disability in this population of 4 or 5 points, you see that this is a very small population, less than 10%, But in this 10% population, more than half of these patients will be deaf or worsened at 1 year. So yes, this score may allow to discriminate a very severe patient in which you can maybe refuse to do the TAVI. But my objection is, I think these patients that are in score 5, maybe you don't need this score to discover that these patients are not to go to TAVI. And most of us, most people doing TAVI, of course, will not do TAVI in these very little special patients. Anyway, the other point is can we do something in this frailty? Can do modify this patient? Lots of papers are going on now about this item, about about the utility of physical exercise, diet interventions, combined interventions, or individually tailored interventions. The problem is that very little inconclusive data are now available. And for what concerns TAVI, there are absolutely no data allowing to say that we can do something for this patient in order to improve the prognostic before doing the TAVI. So if you have to resume, let's go back to our previous balance between risk and benefit. We have seen that most of the patients that are proposed will go to the TAVI. But the question I have to answer is there some patients for which TAVI will be futile and for which we can affirm that the futility due to frailty is determined by a score basis. In this case, which is the cutoff value that will allow us to tell the patient, no, you won't go to TAVI, and we're going to propose you some alternative care plan. Well, let me see that I have some objection at this suggestion, because I think there are two very strong limits to this way of thinking. First of all, frailty features, I think immobility, anorexia, cachexia, may be directly due to aortic valve stenosis and may be reversible by TAVI. We all have some examples of patients that are in a very, very dramatic state before TAVI and that are transformed by the TAVI because all the features that we may think are due to frailty, in fact, were the result of the aortic stenosis and the low cardiac output. Second, we must have in mind that frailty varies with time and intercurrent morbidity problems, and that frailty may be reversible with correction of these features, maybe dietary, physical therapy. So we can maybe think that in the future we will be able to prepare this patient to affront the TAVI in the better condition. And at least it's a more general thinking. What are we really consider when we calculate risk score? Are these scores truly a measurement of frailty, or only and simply another comorbidity index? So we must be we must be sure that we not confound frailty and comorbidity. These are two different things, even if they are very often intricate. So in conclusion, we can say that yes, frailty scores classify patients at high risk for adverse events. That's right. Yes, scores may facilitate the prospective assessment of frailty among patients undergoing TAVI, but we have now no available data for a cutoff value that would allow us to contraindicate TAVI. In fact, futility assessment of TAVI must rely on the individual clinical evaluation by a multidisciplinary approach with active involvement of geriatricians, family members, social workers. And further research is needed to understand the stage of clinical frailty that is not remediable. So I quite agree with Tonen in a recent editorial that says that for the foreseeable future, scoring systems used at a single time point will be of more use for health economists and health administrators than clinicians. Well, we can regret it, but maybe we can rejoice to see that such a difficult decision can take only by using clinical skill, clinical experience, and clinical judgment. Thank you.